thank you all for coming. I think it's just wonderful to see a large turnout for what I would have imagined was a relatively dry topic. But for some reason, it's not considered dry, I guess, by this group at least. And so thank you very much for coming and showing your support and your engagement with this. What I think is very important, very urgent, and problem, but also a highly soluble problem. That's why we called our book Mission Possible. But the solution is not easy. The solution requires political will, and political will comes from the citizens. And I think the purpose of doing these kinds of sessions is to get our citizens engaged in what we believe, we can all agree is a very important topic for us, and get the citizens to bend the political will in the right direction. So that's kind of the larger objective. Now, there are lots of books on healthcare in India. They are either written by expert policymakers, economists, people from the government, or they could be written rather polemically by people who have experienced healthcare and felt very frustrated by it and vented their feelings in the form of a book. So the first form is the descriptive manner of writing. The last form is prescriptive. They say, okay, this is terrible, this will change, this is... So we have tried not to take either of those extreme stances. We have said we will be generative, using what is now becoming a very fashionable word, in terms of ideas. We said we'll put out a large number of ideas, and these are not ideas pulled out from blue sky. This is ideas based on our experience, our knowledge, and plenty of secondary research of what is not just happening in India, but what is happening outside India as well in healthcare. So it's really a book about possible solutions. This is not a singular event. We hope that we can run these events in other cities as well, because getting large numbers of citizens to engage means that we have to go to wherever they live. So the UHC Dialogues, as I call it, is a conversation that we facilitate between various people interested in universal health coverage. And we hope to take it as a multi-city event in this journey. So we all know the definition of what universal health coverage actually means. So clearly India does not have universal health coverage, just for make it very clear. In fact, if you go strictly by this definition, even the United States does not have universal health coverage, because lots of people in the United States who do not have adequate health care. So it's kind of an ideal goal. The objective is not actually to meet that ideal in every sense, but to get as close as possible. That's kind of the larger picture here. And key for India is the highlighted portion or the bold portion, which is without financial hardship. I think accessing healthcare without financial hardship is very easy for all of us in this room. And it's very difficult for some of the people who are not in this room. Lots of Indians who are not in this room, for them, accessing healthcare means financial hardship, which means they don't access healthcare when they need it. But even for us, the middle class and the upper middle class, it is going to become increasingly hard to manage the costs of healthcare. Because if you look at intensive care admissions, these are runs in lakhs of rupees per episode, right? And if you don't have adequate insurance, then it's money coming out of your pocket. And if you don't have land to sell or a flat to sell or something else to mortgage, you are usually put in a very tight situation. So I think going into the future, especially with some of the newer technologies, for example, CAR T therapy, right, for cancer, can cost lakhs of rupees. I mean, we're talking about tens of lakhs of rupees. We're not talking about a few lakhs, right? If you want to have proton beam therapy, right, that can again cost 20 to 30 lakhs per treatment. So if you have the unfortunate situation that a family member needs this treatment and you have to spend 20, 30 lakhs per episode, then increasingly even the middle class will be suffering because of lack of healthcare. So I don't think it's a problem of the slums or the lower income strata. It's a problem for all Indians, except maybe the very thin sliver at the top who can travel anywhere in the world and get the treatment they want. So I would say, why would we care about the healthcare? I mean, first of all, of course, we selfishly care about healthcare because it affects us. But why would we care about healthcare for the larger numbers of people who may be drivers or maids? There is a moral obligation, right? We have a moral obligation to our fellow citizens. If we live in what I would define as a just republic, then it is incumbent on us that all of them have access to the same healthcare that we take for granted. Right? So when we fall sick, we assume these things are available to us. Why would any Indian citizen not have access to the same things that we take for granted? So what is our situation? Now, India has made a lot of strides in terms of healthcare over the last 2 or 3 decades. But this has primarily been in the area of communicable disease. And communicable disease have been conquered mainly because of vaccines, sanitation, better nutrition, and antibiotics. Now, we have reached a stage in our demographic transition where communicable disease is becoming less of a problem. It is still a problem, but it is less of a problem proportionately compared to non-communicable diseases. And it is non-communicable disease, not a disease of the rich. It is a disease of the poor as well. Because if you see the rates of obesity in India and overweight and obesity in India, it is across socioeconomic strata. You see a growth in diabetes, obesity, and overweight. So this compares Canada. And if you consider, I mean, there are many countries one might consider as having ideal healthcare, Canada being one among them. It may not be the absolute best. There are better countries, but Canada is a sufficiently large country that the statistics are more meaningful. DALYs is disability adjusted life years, and basically years of life lost either because you're sick or you die, right? Premature death. And DALYs per 100,000 population in Canada is 28,000. In India, it's 34,765. So you may say India is doing pretty well if the difference is only so small. But then when you standardize this for age, because the Canadian population is older, then you find that the difference is much starker. There's an 80% increase in DALYs in India if you standardize this for age. So it is 7,800 in Canada and 14,000 in India. Life expectancy, as you would expect, is about 10 years less in India. Healthy life expectancy, which is more important, is again about 10 years less in India. And then this can all be wrapped up into something called the UHC index score, which is a composite of 14 different measurements. India stands at 63, and Canada is at 91. And what makes this more stark is the last column where you show the rank of India among 195 nations. India is somewhere between the 120 and 140, right? India is actually ranking close to many of the countries. Sudan, for example. Sudan is somewhere there. We are not anywhere close to the European nations or the OECD countries. So we still have a long, long way to go in terms of our healthcare. Now, there are other numbers I've put there. For example, the dire shortage of doctors and nurses. These are not consequences, these are causes. You can say that we don't have enough doctors, therefore we have more untreated illness. So if you look at GDP per capita, and I think it's important we don't look at how much we spend on healthcare against national GDP. I think it is more important to look at how much we spend on healthcare as per capita GDP. And there, even there, given that our per capita GDP is much lower than Canada, even there we still spend even less on healthcare. We spend 3.3% of per capita GDP on healthcare. This is not adjusted for purchasing power, but without adjusting for purchasing power, it is about $83 per capita, 3.3% of GDP for India. $6,000 for Canada, about 12% of their GDP. So clearly Canada outspends us, even if you adjust for purchasing power. A price of hip replacement, and this is taken from the Ayushman Bharat reimbursement, right, from one particular state. It's about $1,500 US, which is 20 times our per capita health spend, right? In Canada, it is 17,800, which is 3 times their per capita. This is private hip replacement in Canada, because Canada has got a government system where it is free, but I have taken a number for private. If you went private in Canada, what would it cost? And because of this, every year some 10 crore Indians are pushed into poverty due to health expenditure. And this is not this is a number coming from the government of India, Niti Aayog. So it may be more, it's certainly not less than that. So, one idea I had was read the whole book here, but I decided not to do that. But just to summarize the book in the form of 7 principles. And if you read the book, if you get to buy the book and read it, which I encourage you to do, these 7 principles don't appear in the book. So this actually was an idea I had after I wrote the book. After we finished writing the book and got it printed, then I said, this is too much for anyone to read. People are doom scrolling on their mobile phones. They're not going to read this book. So why can't we summarize in the form of 7 principles? So I'm just giving you the 7 principles we think underlie most of our recommendations. The first one is kind of obvious, but if you look at it closely, it is not the obvious recommendation that is made, right? The recommendation that is made is that we should invest more in primary health care, which is also preventive. What we are saying is even more extreme. We are saying in the hierarchy of healthcare, primary healthcare, which we would rather call comprehensive healthcare, should be at the top of the pyramid. In other words, it should be the comprehensivist, which is what we think we should call them, who's a generalist, who dictates and decides when and where and how specialist treatment is given. He or she may refer to a specialist, but the generalist at the front end should be the one making that decision. There should be no instance of, for example, people going directly to a cardiologist unless they want to pay out of pocket themselves. In a system that is government-owned and government-run and government-sponsored, everybody should have a comprehensivist who they go to for and who's capable of taking care of 90 to 95% of what bothers them. For the 5% that they need a cardiologist, the generalist, the comprehensivist will decide, yes, you need a cardiologist, I'll get you a consult, right? So that should be a rare exception relatively. So in that sense, our vision for primary healthcare is not primary healthcare, it is comprehensive healthcare. And we call them comprehensivists who may not be just your plain vanilla MBBS doctors who hardly know medicine when they graduate from college, but there might be the need for supplementary training to get them capable to provide this kind of broad-based general care. The second thing is, if you go to your bank or if you use one of the investment platforms like Zerodha or something like that, it's highly automated. In fact, when I had to open a Zerodha account, I have never met a Zerodha employee in my life so far. I just get to see Nikhil Kamath on social media all the time, but I have actually not met a Zerodha employee. But if you look at healthcare, it's completely run like a cottage industry. You have to quite often call somebody on the phone to fix an appointment, and then you go there, that person is not there or he's busy seeing other people, and you might have to come back or wait for hours to see the doctor. And then the doctor sees you and scribbles a prescription, which only the pharmacist will understand. And when you go next time, unless you take that prescription, the doctor does not know what he or she did for you. And 5 years later, there is absolutely no memory in anybody's files of what happened to you 5 years back, right? This is a common practice. It is probably becoming less common now, but it is still largely the experience of all of us. And we all know, especially physicians know, having a longitudinal track of how the health is moving is very important in diagnosis. And all the tools are available. I mean, if we can do UPI, we can certainly do healthcare online. We can certainly do electronic health records. So why are electronic health records not happening? And this is going to be a point of discussion. Maybe Meena will help us understand why technology is not sufficiently deployed in medicine. And I have my own theories on that, which is exposited in the book, but I don't have time to go into that now. Maybe in the discussion. Payment, right? So what we are saying is payment at the front lines should be completely friction-free. There should be no billing section at the comprehensive care center. There should be no need for payment, right? And in healthcare, if you provide everything free to everybody, there is the moral hazard, right? I will continue to smoke, knowing that when I get cancer or respiratory disease, I will get free treatment. So there's a moral hazard. There are ways for dealing with that. You can give people negative incentives for not getting preventive health checkups or not following prescribed lifestyles, right? For example, you can give everybody a token health credit, a credit to their bank account. It's a non-income encashable credit, right? But they will be allowed to encash it every 3 or 5 years, a small portion of it, if they have had all their preventive health checkups. If they have not had their preventive health checkups and not compliant with their medication, they will not be able to encash it. At least for those in the lower socioeconomic strata, it will act as an incentive to avoid the moral hazard problem, right? So we need to have those kinds of incentives for people not just to get free care, but also be punished in a sense for not accessing that free care. So this is, everybody understands that there is a lot of waste. I mean, there are a couple of examples given in the book. For example, we see doctors prescribing antibiotics for viral illnesses, and antibiotic resistance is a huge problem now. This is both, I would say this is a triumvirate of fraud. I mean, triumvirate of problems, right? It's a waste because antibiotics are expensive, somebody's getting an antibiotic is not necessary. It's a fraud also, in the sense that often the doctor may be getting some incentives from a pharmaceutical company to prescribe a particularly expensive antibiotic, right? Not in all cases, but in some cases, right? And it is also an error. I think many doctors don't take the time to evaluate the patient, doing a physical exam to see whether is it a viral infection or is it bacterial infection. Do I need to prescribe antibiotics? So this, unless we plug what we call wafer, just scaling up universal healthcare means that we are putting more money into waste, fraud, and error, right? So we have to be very careful. We have to fix this problem of fraud and error and waste before we expand healthcare in the country. Right now, that's not happening. If you see that you're opening up more hospitals, more doctors, but 50% of what we are spending may be going into wafer, and therefore we are not getting the bang for the buck. Not-for-profit sector is cost-efficient and compassionate, but not-for-profit sector is not necessarily always very bringing in new business practices into how they deliver care. So we need a blend of not-for-profit and for-profit. What we have said very strongly in the book is all kinds of discretionary care, for example, emergency care, right? You have a heart attack and you go to the hospital. That kind of care should be in the not-for-profit or even government-regulated sector. But all kinds of elective care, you have a chronic appendicitis, you have an elective appendectomy or a joint replacement, or even an elective coronary bypass, that is when you're fine having a preventive coronary bypass, those can be in the for-profit sector. Because you can, in those cases, aggregate 1,000 joint replacements, send them all to the same private hospital, and negotiate a fixed fee, which allows the private hospital to make a reasonable return on investment, but without giving them the flexibility to kind of prescribe unnecessary things and do unnecessary treatment, which happens all the time in medical care, right? We get prescribed unnecessary investigations, unnecessary treatments, and you can prevent that by having a negotiated fixed fee for elective procedures. So we think we need the for-profit sector. We are not saying that we are having the for-profit sector because they exist and we want to let them live. No, that's not what we are saying. We are saying actually the for-profit sector will bring value to this because they are good at running businesses. And when you're aggregating cases, doing 1,000 joint replacements in one center, then having the efficiency and the process, business process efficiencies of a for-profit organization can bring immense value. St. John's may not be fantastic in doing this, right? St. John's could be, but they may not be fantastic at doing this. So maybe we need an Apollo to get into saying that, okay, I'm going to offer to the government of India 10,000 joint replacements at all my hospitals, and I'll have a prefix rate for this, and you can just send me, I'll do it at that prefix rate. I won't charge anything extra, right? This one is a fairly simple one. We will, for example, this wellness clinics. You know, the government has got into this wellness clinic thing, right? And then they have got this All India Institute of Medical Sciences. They'll have these piecemeal interventions, and each of these interventions has a knock-on effect somewhere else. For example, the All India Institutes that they have started 25 of them. All of them are not operational yet. What they do is they suck up good talent from the locally neighboring state hospital. The best doctors there will want to go and work in the All India Institute. They are, even despite that, they are still not able to get the sufficient staff strength, right? So they built up this building, and they don't necessarily have all the equipment. And it just increases the cost of care for the community, because multi-speciality general hospitals are very good at solving complex problems. And if they have to justify their existence, you can be sure that they will make a simple problem complex in order to justify their existence. So having more All India Institutes of Medical Sciences is not the way to go. But somehow the government has felt that having more AIIMS will make people healthier. We actually feel that AIIMS will make people sicker. We do need 1 or 2 AIIMS in the country, maybe one for the north and one for the south and east and west, but we don't need 25. And this is because we don't take a whole system, ecosystem approach. The final principle is we let the government off very easily, right? We say that the government can't do this, nahi ho sakta hai, these are all bureaucrats, they don't understand, they're corrupt. We are letting the government off the hook. The government is capable of doing very good work, and I have actually written a book about a government hospital where a plastic surgeon set up one of the world's best hand injury centers in the world, right? So I have the faith that it's all a matter of individuals, people. It is not a matter of organizations. The government can, should, and we should expect the government to do the best healthcare possible. So I think the government should be in control for key elements, for example, creating a digital backbone for your healthcare in the country, which the government is already doing, right? They are creating the digital backbone, but the problem is they have allocated, I think, around 200 crores or something like that for creating a digital healthcare backbone, which Meena would attest is not even a drop in the bucket, right? So the intent is there, but it's not serious. We need to tell the government, create today an electronic health record for every Indian, which is mandatory, because when they go to their comprehensivist, he will have access to it, and he will want to have access to it, or he'll create one for you to treat you. And the comprehensivist has to become the funnel for healthcare for us, for all of us. We should not be allowed to go to a cardiologist or a nephrologist or any super specialist directly. Each of us have an assigned comprehensivist, and he or she should be the first person we contact. He or she will have our electronic health record. We will own our health record. He or she cannot do anything without our permission. And that is the kind of system we need. It doesn't cost a lot of money to create an electronic health record for 1.4 billion Indians. But only the government can do it. Private individuals cannot do it. Although I know that there are a lot of private companies trying to create their own versions of electronic health record, which is a very dysfunctional way of doing something that has to be a mass movement. Some loose but important ends. I think we need innovation in terms of business models. One of the things that works very well is physician controlled. If you have nursing homes, for example, many nursing homes have got excellent reputation because they're owned and operated by physicians. A local physician has enough skin in the game and exposure to the community surrounding them that they're very careful in how they run their facility. The moment you replace it with a private equity-owned multi-speciality hospital, where the owner is a corporate entity, that connection to the community is completely lost. And all they are interested in is making the maximum profit in the shortest period of time. So I think we need business model innovation where the ownership models have to change from being the classical expanding corporate medical centers to many of these non-corporate style ownership models, which actually work, which can still be private and still be for profit, right? Operating model innovation, focus factories, I already talked about how we can aggregate elective care and provide it in focus factories, which can be owned by private entities in government infrastructure. The hospital can be built by the government, but a private entity comes and says, I will manage it, and I will do these 1,000 joints and surgeries here. And the reason you might have to do that is, you might have to cancel that contract next year because the private guy is not giving you the clinical outcomes you want. And then you don't want him to take away the hospital, right? The private guy is just a manager. He runs the hospital, processes, etc. But you can kick him out if he's not delivering on the clinical outcomes and cost structures that are important for you, and bring in somebody else. This is similar to the hotel franchise model, where you have a Marriott, but the building is owned by somebody else, right? I already spoke about the encashable health credits. I think we really need community participation. I need to know who is the comprehensivist in my neighborhood, and I should be measuring what are the outcomes they are generating at an aggregate level, not at an individual level. But I should know, okay, if we had so many acute myocardial infarctions, how many of them are alive after three years? I should be knowing that. And I think the government had these Rogi Kalyan Samiti, and they still may be operating in places. But we need to strengthen the ability of the local community to judge and evaluate the performance of the comprehensive health centers. Finally, there is a state-center schism in the country. The state does something, the center does something, completely uncoordinated. I think we have a GST council model where all the states come together with the center in agreeing on GST rules, and then the states implement it. I think we can have something similar in healthcare. So I'll now stop talking about the presentation, and I will introduce the panelists. So we have panelists of very eclectic nature. They represent multiple domains. Dr. Ashok Velodi is a pediatrician who moved to the UK and worked in the NHS from 1979 to 2016. And his current interest in the health of tribal communities and the effect of climate change. So Dr. Ashok Velodi. And then we have Dr. Arvind Kasturi, Chief of Medical Services and Professor of Community Medicine at St. John's. He is interested in elder health and has launched a service that addresses their needs. He is currently established in the Geriatric Center at St. John's. And Meena Ganesh, co-founder and chairperson of one of India's largest home healthcare companies, Portia Medical. She's also a partner on growthstory.in, which is an entrepreneurship platform. And in that role, she has co-promoted many new age and tech companies, ventures, Big Basket being one of them. And my dear co-author, Aparajithan Srivatsan, where is he? Oh, there he is. Okay. So he's a well-known name and face in the healthcare industry. Without him, I would not have had the guts to write this, because I come from a completely science background, biopharma. I'm a medical doctor, but I've not practiced a lot of medicine. So I have mainly worked in drug discovery and the biopharmaceutical industry. So without the strength that he provided, this book would not have happened. He comes from the hospital sector, and he calls himself now a hospital strategist. So I invite all the panelists to please take their seats here and
good evening, everyone. Thank you, Swami, for setting the context. Before we get started on the discussion, I just wanted to make some introductory comments. Yeah, is it on? Are you able to hear me? It's on, right? Yeah. Okay. These days, I receive a lot of calls from family and friends, a lot of questions relating to health issues that they're facing. The easy ones tend to be saying, I'm just retiring and I want to get myself insurance because my company insurance will no longer be valid, or someone has the fact that their claim is getting delayed, or they want to go see a specialist. The not so easy is when they ask me, saying, I want to go see a general physician, or they say that the insurance company is disallowing a part of my claim. The most difficult one is when they say, how do I enroll my domestic worker into Ayushman Bharat? Or how do I help the domestic worker access medical treatment? Now, on the one side, we're reading about the government increasing the number of medical colleges and the intake of MBBS students, but we all know how difficult it is if you want to go consult a GP, even for all of us in this room. For 90% of India's population, this is a huge challenge. One of the things that we have talked about in the book is how to address this by creating a cadre of community health workers, frontline community health workers who are tech-enabled. And I want to use this as a starting point for our discussion today. So I want to start off with you, Meena. you're doing a lot of work in developing this cadre, right? So I want you to share with us, saying, why do you think that community health worker is an important element in delivering UHC? Also, talk to us a little bit about how much of task shifting can we do, right? Today, we are a physician-centered system where for everything we want to go see the doctor. There are doctors in the audience who will nod that, you know, the patient comes and says, can you just see me for a moment, okay? So how much of task shifting can we do? Also, that you've kind of envisioned the community health worker to be an entrepreneur. So how does this play out differently? The government has already created the ASHA worker, who is meant to be a community health worker, but who has not been as effective. So could you talk us through all of this, please?
Sure. Thank you, Srivatsan, and thanks for having me here today. I'm speaking about this from two vantage points. One is Portia Medical, which is into outside of hospital healthcare, which is basically doorstep delivery of healthcare. And the other is through my foundation's work in Bastar, in exactly what you said, the community healthcare entrepreneur model that we've been piloting in those two places. So first and foremost, one of the realizations that we had through Portia is that there's a lot that can be done outside of facility. I mean, that was the thesis with which we went, that today, or about 12 years back when we started, everything required people to go into a facility, whether it's your local clinic or a big hospital. And more people are tending to run off to the large hospitals for a stomachache. You'll go directly to the gastro department and register yourself. So moving from there, how can we move some of the care into people's homes? Now, there are multiple reasons and multiple use cases that we looked at. One is, of course, for senior citizens. It's difficult, bring the care home, easier, more convenient. They're more likely to access healthcare and so on. Otherwise, they just let it be. It's too difficult, too time-consuming, too much of dependence on the family members to take them and so on. So how do you get it so that they actually are taken care of? The other is that step-down care, people recovering, they need a home to rehabilitate and recover. You can't recover in a hospital. So those are all very interesting and important reasons to take healthcare to the doorstep, which we've been doing. But the third piece, which is starting to really become center stage, is that how do you care for a person's health over a longitudinal period, not just episodic? Somebody's sick, handle it at home rather than in a hospital. It's easier, it's cheaper, maybe better for the community, better for the individual, all of that. But how do you manage their health over a long period of time? Now, that is something which is starting to become very interesting, and I think healthcare is a very long, patient period time you need to spend. First 10 years, I may have done that, but the next 10 years, I think, is about making sure that we can manage people's health over long periods of time and become, as you said, their comprehensivist. So you come, you take care of them, you then refer them to things that they need to get to, but then when they come back home, you continue to remain their primary go-to healthcare provider, manage that, and then see them through the episodes that require hospitalization. It could be emergency, it could be criticality, this could be something that requires surgery. You go there, come back, go there, come back. But we provide the common thread across all these different episodes, which obviously requires technology. As you rightly said, you need a platform through which you can track all of that, which being a private company, and our whole intention was to be all India. So first thing we said was let's build a platform so that we know how the patients are doing. Using that platform, we are now seeing that we are able to do those longitudinal care programs for patients.
Okay.
So that is on the paying urban population. Now let me just shift my gaze a little bit to the work that we're doing in Bastar, which we all know, Naxal-ridden, very, very remote villages. I mean, I didn't know how remote it could be till I actually went there to see that Jagdalpur is the local town. From there, you have to take a cab to go to any of these places, and it takes about 2.5 to 3 hours to get to the closest village from there. In a cab, please note, which is paid for. Now think of the people in the villages who have to go there to get, they're not going to do it. They just forget it and let it be. So for them, access to, and there was not much of a public health system 7 kilometers of walking through Pagdandis to get to those places. They're not going to do that. So we created a model of taking people from the community, women from the community are well embedded, train them on basics of healthcare, provide them with some basic point of care devices, provide a sort of supervision model for that, a remote supervision model, and also some local supervision model, combine the two, and then let them become entrepreneurs. So they earn small amounts of money by providing basic healthcare diagnosis, both for primary as well as chronic illnesses, and then layer on top of that some teleconsultation and medicine delivery. So at least we have the basics taken care of and then refer them to the public health or the private health system for things that cannot be managed there. Now, both of these are very different models, different use cases, but even in the second model, we are seeing the communities are pulling for this. It's been about 2.5 years that we've been doing that, and the communities are asking for it. So after the first batch, when we went to the second batch and said, we want to do this, the communities came forward and said that we absolutely want it. Please enroll us. Our team, our villages want to cover this because we find that this is helpful. The other interesting phenomenon that's happening is that the government is also saying that, okay, let's use these as the last mile delivery points for some of their programs. That they had a malaria on Mukta Andolan, so these girls got signed up for that. They did a sickle cell anemia diagnosis program, so they got signed up for that. So the DHOs are also seeing these as potential last mile delivery. Now, you would ask, where does it come? Conflict with ASHA, because there should be ASHAs, and why the ASHA model is not working. The coverage of ASHA is not adequate, and definitely in these deep rural areas there is not much. ASHAs are extremely overburdened by the maternal and child health and vaccination, those kind of programs. Their incentive schemes are a little loosey-goosey. They get paid at the whim and fancy of the powers to be. So it gets a little challenging to get the ASHA to be always motivated and do a great job. Some states have done a much better job. When I go to Tamil Nadu, to Nilgiris, I find ASHAs are fantastic. They do a great job. Not so much in Chhattisgarh. So those are some of my observations.
Thank you so much. Dr. Vellore, I want to bring you into this conversation now. You spent many years working in the UK, in the NHS. In India, anytime we talk of health reform, people stand up and say, oh, we should go the NHS way. Now, clearly, the NHS is an expensive proposition for India to implement, but there are elements that we have come across which we think are very handy. One is, of course, the focus on primary care and prevention. And also, we are now starting to read about how in the UK, they are experimenting with a cadre of community health and wellness workers, they are calling them, which they believe can be a very effective response to the problems faced even in a country like the UK. Could you please talk us through that?
Yeah, but working. So, thank you, and thank you for inviting me today. Yes, I completely agree with you that the NHS model in its entirety is not workable here, but I think there are good things about the NHS that can be extrapolated. And one of the things that's come up in 2022, the British government recognizing that health is not just about delivering health, but delivering social care as well. It has to be holistic, and it has to be sensitive to the needs of the people. At the same time, there simply isn't enough money in the NHS, and it doesn't have the reach that's required. So what they've established, the first pilot project was established in the west of England, and they call them the voluntary, the VCFSE, I think the Voluntary Center Faith and Social Enterprise. So what they do is they combine, they make partnerships with voluntary organizations, religious leaders, that's faith and social enterprise. And one thing I've not seen much about, I've read a little bit about it, is how effective religious leaders can be in promoting healthcare in the right way. They're very powerful. They appeal to the masses in a big way. So they've established this. And what they do is they've established what's called integrated care pathways in the United Kingdom. And there are something like 42 now across the UK. And they're working extremely well. I think obviously it was only established in 2022, the first one, so it's a little difficult to know what the long-term effects are going to be. In other words, what is going to be the outcome. But before that, I can tell you, having worked in the NHS and being very closely associated with community care for many years, community physicians and pediatricians there are not looked down upon, but their work has become more and more difficult because of the fragmentation of primary care in the UK. I don't know how much you know about the funding of the NHS, but that's a completely different topic. Anyway, what I'm saying is I think that is something that could be implemented in India. So you could have a combination of healthcare providers. So instead of voluntary organizations, you would have the NGOs, and you would have social care organizations who were aware of the social problems such as gender inequality, poverty. See, poverty in India is not just fiscal, it's multidimensional. And that has a huge impact on health. When it comes to Ayushman Bharat and the design of Ayushman Bharat, defining poverty was one of the major flaws, actually, in Ayushman Bharat. Anyway, there are many NGOs that are doing excellent work, and I think their reach in reaching some of the most vulnerable populations, their experience can be tapped into. So I think this system can be used.
Thank you for your comments. I want to get Dr. Kasturi into this conversation. The last few months, there's been a lot of noise about the government wanting to extend Ayushman Bharat coverage to the 70-plus population. Okay? Now, clearly, providing them financial cover is one aspect. However, how do you provide comprehensive care to an older population that is also underprivileged? Okay? And I have another question that I'd like you to also answer, is that when you look at this segment, this is clearly a segment which consumes a disproportionate share of healthcare services. So at some point, do we need to think in terms of rationing of care? And if so, how would we do it in a fair manner?
Okay, yeah, thanks for that question. Okay, let me try to see from which perspective to answer this. You're asking about specifically the senior population. Yes, at St. John's, we run a program called the Senior Citizen Health Service, where we run rural geriatric clinics in about 6 or 7 village locations around our rural health center, which is in a village about 30 kilometers away from St. John's on the Sarjapur road beyond Sarjapur town. We also, more relevantly to the second part of your question, run a clinic for older people in an urban underprivileged area, a congested place in Austin town, for those of you who are familiar with Bangalore. So what are the challenges of delivering healthcare to older people? Well, I think first of all, when we started the rural geriatric program in 2002, 2003, there is a certain acceptance among populations who feel that when a person is old, yes, he will fall sick. I mean, what's the big hoo-ha about this? Why do you want him to come? Yes, he is old, what do you expect, kind of a thing. So, in fact, when we started, we weren't sure about the uptake of this. I mean, would people actually come? Would people send their people at home, etc.? But over time, we find that if, just like with any other community health initiative, if you're there, you're consistent, people know you're there, and you have their trust, people will access care. So the barrier of access is one of the things that confronts the older population, especially the rural elderly population. Urban underprivileged is also, I often say that the patients we see in our urban geriatric clinics are even worse off than the rural geriatric clinics in terms of their social and economic situations. Many of them have families which are broken, they don't know nobody to take care, so many problems. But challenges in delivering healthcare to older people, definitely access is one. Creating the awareness that actually something can be done for an older person, even though that person is old. And promoting what we call health literacy is another one. And trying to see how we can keep the cost of care low. Because inherent with age is the increasing prevalence of chronic disease and the requirement for more and more of medical and healthcare intervention. So with all that, how is it possible for us to keep costs low, keep basic medicines which are required in the pile and not a long prescription of about 17 or 18 drugs, some of which interact with each other, some of which may not be necessary, and things like this. So bringing these, I think these barriers of access, affordability, awareness, would probably be three important issues in dealing with healthcare of older people. Now, rationing of healthcare is, I guess when you say rationing of healthcare, you mean, correct me if I'm wrong, Srivatsan, when a person reaches a healthcare point and there is a competing interest between, let us say, an older person and a younger person, like what we used to read about in the COVID-19 pandemic time. Do you reserve this ventilator for the younger guy or the older guy? Something like that is what I'm assuming you're asking about rationing. Well, I personally cannot take that call. I do not feel that any human life is really less valuable than any other. So while, yes, no doubt that one has to face some form of what is available, make it equitable, no doubt, but rationing from that perspective, I am not so much the person to ask. So I'll leave you there at this point.
So, based on the responses from all of you, I want to kind of close this segment with a question that any one of you could answer, which is saying, you talked about the community health worker, Dr. Velodi talked about the primary care physician, Dr. Kasturi talked about how, you can kind of provide care to the growing older population with chronic disease. Do we envisage a situation where between a community health worker and a physician, they can take complete ownership of providing healthcare to a large chunk of the population? What must happen for this to become reality? Any one of you could take this.
I guess Meena will also, she was shaking her head, I saw as you were asking the question. The reason I'm saying this is because of our rural geriatric clinic model. Now, what is it? It is a clinic which runs in a village location on a fixed day every month, which means the 4th Thursday or the 2nd Tuesday or something like that. Every 4 weeks, a team of guys from St. John's, along with community health workers and a nurse, land up there and run a clinic exclusively for those aged 60 and above. Then we come again 4 weeks later. And this allows us for the kind of longitudinal follow-up that the older population needs. And the health record that we have is a notebook. And when I say notebook, I'm having nowadays to say it's the one where you write on a paper and a pen, which is actually the older person has. It's a patient-retained record. And he or she brings it with him every time they come, and then we leaf it back, and I can see the whole history of the past 2 years in that notebook at one glance. And so we look at the person, after a physical, we prescribe medications. We ourselves take a dabba of medications, go and sell it at a low cost. We buy at low cost. We subsidize it through donations and things. And we sell it at low. We don't give anything free of cost. Swami, a point taken. And so now, between these 4 weekly clinics, our community health workers visit the older persons who need to be visited. Not all older persons. We learn in geriatric medicine that one of the characteristics of the older population is heterogeneity, which means that just because a person is 65, he's not like the next 65-year-old. There are 40-year-olds who behave like the whole world is on their shoulders, and there are 75-year-olds who say, I don't want anything to do with you. I'm leading a happy, beautiful life. So the community health worker pays a visit to the homes of those who are probably older or frailer or sicker, and just to see how they're doing, see if compliance is happening, adherence to medication, and reminding them about the next clinic. So community health worker, I feel, is an essential part of any program that you wish to do population-based and not clinic-based necessarily, but if you're looking at reaching out to people in populations. One more thought and I'll hand over the mic. Our rural health center runs many programs. One of them is the Senior Citizen Health Service, but there are others. There's a community mental health program, a community eye and ear care program, etc. The reason I'm saying that is because the community health workers who are sort of fixed to those programs, we have trained them. For example, there are community health workers who will remove a foreign body from the ear beautifully. In fact, some of our interns have a look at how they're doing it, So it is possible, just like Meena said with the Bastar experience, to train community health workers to actually do a very wide repertoire of things which physician need not do, and many times the kind of graduates we get these days may not be able to do, here and there. So that's my thought. Community health worker as a part of the team is a very, very important cog in the wheel.
So I understood your question slightly differently, that today's family physician or your local generalist, what needs to change for them to become your go-to person? So for me, that requires so many things to change, ranging from something basic as technology through which they can track you, have your record, so that when you go them, there is a sense of persistence. It's not just because you've interacted for 25 years and they know your mother and your grandmother, so they know everything. Not just because of that. If it is there, great, but at least they have the data at their fingertips. Second, they need to inspire confidence that they understand different aspects of you, and they will refer. And when you're finished with that referral, you do still want to go back to them to say that I went and did this, but I'm still not okay, or I'm feeling better. Do you think everything is okay? How do we create that competence in them and the community trust? That is the problem that I think is the biggest problem in my head that needs solving. I don't have the answers. I'm just saying what needs to be done. You are the solutions guy. You can suggest how to do that. That is the problem. I go to a generalist, they will say, okay, you have this disorder, go see the gastro. I'll go to the gastro, I'll never come back to them. And if I don't go back to them, they don't know. And I don't go back to them because they did not inspire confidence in me that they're going to continue to stay in my life, and they're going to advise me going forward what needs to be done. But we always, all of us, I'm sure, have one go-to person in our family who we feel confident with. We will go and talk to them about I'm a non-doctor, okay, but I am the go-to person to everybody in my family. For some reason, for the last 12 years, I've been in healthcare, so now they have branded me a healthcare person. So I become their comprehensivist. So I'll tell them, oh, go see this. Okay, ab kya hua? Tell me. Okay, this happened. Okay, can we, maybe you still need to see so and so and so. So how do you create that family kind of feeling in these guys so that they become linked with you? Because today everybody runs to the specialist hospital. I mean, we just go there. Like, we think that's the right path. So it's a lot broken there.
Yeah, I think two things need to change. One is accountability. So physicians largely in India are not accountable. It's a joke. There are no committees, general committees like the General Medical Council in the UK to make sure that physicians are doing their job properly. There are no regular appraisals, nothing's happening. So by and large, people do what they want. Now, that's not true of everyone. That's a generalization. But there need to be some sort of checks and balances in place. In the UK, you have what's called the Care Quality Commission. The Care Quality Commission visits every single hospital in the UK on a regular basis to make sure that certain standards are maintained. So that's the first thing that really needs to change. The public needs to see that physicians are accountable. Only then can there, well, that is a sure pathway to trust. The second is fiscal management. So we talked about the health, I mean, it's not directly related, but to make sure that the community health officer and his team have enough money, one of the problems is that the healthcare budgets are not devolved properly. Only about 60% of healthcare is being devolved properly. The public finance management system in India is defective. That is very patchy. Some states do it better than others. But essentially, people at panchayat level are not getting the healthcare funds that they need. So these two things need to change. The CHO and his team need to have the money to work with.
I want to now move to a theme which Swami explained, which is the use of technology, automation, and industrial concepts, because we believe that that's what's going to make delivery of healthcare services more efficient, which is a key to delivering universal health coverage. Now, one of the proposals that we've outlined in the book is to separate what we call as standardized care from customized care. Standardized care is the kind that can be automated, could be put into a factory kind of a process. We are already seeing that happening, for instance, in the ophthalmology space, where there's a lot of cataract procedures being done that way. Also, a lot of centers that deliver childbirth in that kind of fashion. I want to ask you to comment on the feasibility of putting other elective procedures into this kind of a process, right? Do you have some thoughts on that?
I think it's a fantastic idea. I think that that should happen on a larger scale. There are certain, you can identify the procedures that could be done sort of almost as a focused factory approach, as you mentioned in the book, whether it's bypass or, angioplasties or whatever. You could have a list of such procedures. It would bring the cost down. It would raise the expertise level, and the patients and the public would have trust. What it doesn't address, of course, is the fact that it's being done in private hospitals, largely, who will charge. And we have to make sure that those private hospitals are empaneled by the national health insurance schemes and that they're paid. So one's reading in the news now that more and more private hospitals are withdrawing from the scheme because they're simply not being paid. So that has to happen. It also doesn't take into account what happens before and after. So you go in, the patient comes in for an angioplasty, but what about the build up to that? Why has he got heart disease? Who's going to look into the family history? Typically, in these families, there is a certain lifestyle that's predisposed to heart disease. And we know that India has a very high incidence of cardiovascular disease. It's actually rising. So when you see a patient, that should immediately trigger a separate community-driven program to say, okay, let's go and look at this family. Let's go and look at their lifestyle. Make sure that the children in that family are not going to follow suit. Number one. Number two, what happens afterwards? What about care after he goes home? Because the hospital will then forget about it. They'll do the angioplasty, you can go home, thank you very much. But who's going to look after them? So we need to have a system, and especially when they come from very far away. It's okay if they live in the city, but if they've come from 100 kilometers away, who's going to look after them? That then goes back to primary health care. So there needs to be a system of communication. But yes, in principle, it would be fantastic.
So, Dr. Kasturi, I want to try and get your thoughts. You also wear the hat of the Chief of Medical Services, and one of the topics that Swami talked about was how do we get waste out of the system? Okay? since we are on the segment where we're talking about technology, automation, and industrial concepts, could you throw some light on how we could address this? How can we take waste out of?
Actually, I'd like to ask you that question in the sense that because we see so much of it happening in a big hospital. That St. John's is a large hospital. We see an outpatient footfall of anything between 2,500 to 3,000 a day. And consequently, a lot of them get admitted. We have a large number of inpatients as well. So waste is a phenomenon which is very real and very disturbing for any healthcare administration. All that we are trying to do is it comes down to a culture or an attitude or a behavioral change that you need to inculcate in your workforce. Because if somebody feels, look, it's not my problem, I'm earning a salary, whether I throw this thing off or this is not working, so I'll get another one, I throw that off. Now, if that's the attitude of your workforce, then there's a problem. So we are trying our best to try to bring in an attitudinal change. We are also trying to document standards of consumables, saying that for this procedure, this is what you need ideally, and you must justify if you need more than this kind of a thing. But that's easier said than done. It's a very complex organism with all kinds of personalities which clash at every moment, but waste is an issue. We try to address it like this, with trying to train, trying to inculcate a culture, trying to put documentation in place, trying to put SOPs in place where you say this is how it should be done, this is what are the things required for this, and try to monitor what actually gets consumed. But we certainly are a long way off from there. I'd just like to share a stray thought with you. When you mentioned, I think Meena also said, when we the patient now feels the first point of contact should be a super specialist most of the time. But I think that is because we are trained, and when I say we, I mean the medical student is trained in a medical college where even the doctor, when he has a headache, he goes to a neurologist. I mean, there is no general physician in a medical college. Now we have a department of family medicine. Family medicine has kind of trying to get into its own. We have in St. John's, we have an MD program also in family medicine. So we've got a family medicine department. But I can see that family medicine department is extremely uncomfortable in this tertiary center. No, which patient is actually going to go there? Every guy who comes is triaged into, what's your problem? Left eye, go there. Right eye, this side, and all that. No, who sees the family physician? So we've got this essential problem, I think, in our system of training, where we do not train our professionals to think generalist. We train them to think specialist. All their role models are super specialists and specialists. So why would a guy want to be this generalist physician, So whereas everybody talks about it a lot. Older population straight away says, don't send me anywhere. You tell me what should happen, is the first thing that older population says. But the reality of the thing is that you don't really have that cadre of people being trained anymore. We have, of course, even a DNB in family medicine, which is happening. But anyway, that was a stray thought. Sorry, let me not ramble. I'm just saying that that could be one of the reasons why people are also, the population follows that profession at the end of the day, because everybody talks specialists, so population also says, if I have a stomachache, like she was saying, I want to see a gastroenterologist, kind of a thing.
Yeah. So, Meena, I want to close this segment with your thoughts on how do you see this whole technology/automation piece play out? Okay? The healthcare sector, like Swami mentioned, has been rather tardy in terms of adopting. Dr. Kasturi talked about using notebooks to keep information. It may be a very effective way to do it, but how do we move towards more technology adoption in the healthcare space?
So there are certain areas where the medical sector, this particular area, healthcare sector, has taken on to technology quite substantially, and that is at the high end. So you'll get your proton beams and you'll get your CAR-T and all that, and we will use that MRI, quite liberally at the high end. But the fundamental that is required, like you and Swami also mentioned, is to have something as basic as the electronic health record, so that all of us know our own health records and the doctors also have access to that. That problem, it's not just India, it's not been cracked anywhere in the world. If you look at, I don't know, I can't speak for UK, maybe the NHS, but if you look at the US also, this is broken. There are a lot of disparate systems. Some of them talk to each other, some of them don't. Or people still use paper and pencil, and you carry your records and do that. I think the core of that is that most of the, in the US at least, and I've been there quite a bit, my daughter lives there, so I have accompanied her. The doctor spends more time looking at the computer to fill up stuff than look at my eye. I mean, really, what's the point? And that, a lot of doctors dislike that, and that becomes a huge friction point for capturing fundamental data. The problem stems right from there. It is a behavior change that you want to bring about, asking a doctor who's looking at the patient, who wants to be really in the patient care, to take his gaze away from there and do this while, okay, bolo, okay. That's not the purpose of the doctor. So how do you change that whole thing? Now, unless you fix that problem, this is always going to be a real hard push. It's not going to happen on its own. Now, I'm hopeful that, and very optimistic, that some of the newer technologies like Gen AI, which can read, which can just listen to the conversation and fill up, maybe 90% accurate, then you go and fix it. Can you start using some of those to remove this friction? You can create the most beautiful, and the government is investing. There's a ABHA number, and there's a health record system that they are creating, and they're asking the private sector to integrate that. Fantastic ideas, but unless you fix this friction, that is going to fail miserably. So I'm hopeful that some of the new technologies may help in fixing that friction.
So we've talked about community health workers, we've talked about primary care, we've talked about technology automation, which we believe are three of the key pillars for rolling out universal health coverage. The fourth one, which is obviously a vast topic, but one on which we don't have the time to go into great detail, but one of the pillars for that is preventive healthcare. Now, preventive healthcare is a tricky one, right? A lot of people in this room worked in companies which have wellness programs. Even if you provide a wellness program and it's paid for by the company, a lot of people don't necessarily go and participate. Okay, now this is amongst people like us, people who are in this room. Now, if you go to the underprivileged person and you say that you have to participate in a preventive health program, how do you ensure that that person actually does? So how do you incentivize there? And I want to get all your thoughts on that topic, saying how can we incentivize individuals in the lower income strata to go and get preventive screenings done?
Well, as you say, it's a huge and it's a very challenging area. I think there are two issues. One is that incentivization doesn't necessarily yield the best results. Sometimes it can have adverse consequences. For example, the JSY program, the Janana Suraksha Yojani, which was talking about giving birth, delivery in hospitals, actually had the opposite effect. There was no, in the poor population, it actually increased perinatal mortality. And in the not so poor population, there was absolutely no impact at all. So you have to be very careful when designing an incentivization program. The second is that people are simply don't have, especially the poorer sector, simply don't have the time to go to an outpatient clinic or to get screened. The average outpatient attendance in India, in the urban population, is 4%. I'm talking about public. In the rural areas, it's about 10 to 15%, which is derisory. So you have to take the screening to the population. And there are some very innovative, some very innovative works being done. For example, I think we've discussed that in Chhattisgarh, for example, they have these huts. So every month, these tribes meet to barter and to exchange information. And at that point, a primary health center will establish a store for simple screening. So you capture the population as they come there. Otherwise, they're simply not interested. So I don't have a...
Well, when you say preventive programs, we have a kind of aphorism in our department where we say the triumph of preventive medicine is a non-event. And that's very difficult to celebrate. You can't tell a guy, hey, pal, you know what, you don't have a stroke. You know, I mean, it's very, cure is a very saleable commodity. You know, he comes with a pain, you give him something, he becomes better, the whole ward cuts a cake and everybody is very happy. But to tell a guy you don't have something because of something you did is a little difficult to push down their throat. So to that extent, I agree. Preventive healthcare is a little difficult to sell. And even when you look at preventive healthcare, we must understand there are layers to it. The primary, that is primordial, primary prevent, what we say things before you get sick, that is don't smoke and be physically active and eat healthy food. This kind of a thing, you require health literacy, you require literacy, you require a population who is in the hierarchy of needs reached a point where he's willing to absorb stuff like this. Otherwise, we are still at food, clothing, and shelter. And for that population to try to sell things like this is going to be next to impossible. However, when you come to secondary prevention, which is screening, that is early diagnosis, yes, now in our old rural geriatric program, we have finally reached the point where now I sit there, I say, okay, Banni Amma Kutkoli, okay. And I open the notebook, there's this, I say, oh, yes, namaskara. So, yen tondre ivatu? I mean, what do you have? What's your problem now? Yenilla, she says. And for a third guy looking, he may wonder, if this lady doesn't have anything, why has she come here? But she has come here to check if all is well, you know. So to that extent, at least, if we are able to sensitize or kind of educate our population, saying that you need to monitor your own health. You want to know your blood pressure. You want to know your blood sugar because it's yours, it's not mine. So you need to come periodically and have a check or whatever it is. Now that just take, I don't know, it's the plod path is the only one. May you keep on at it and finally you reach a point where your population has understood the value of periodic health checks and screenings. So whereas the first part is difficult, the second part I think is achievable and doable. I'll stop there.
So just to add to what Dr. Arvind said, that even in my rural, deep rural villages, I'm seeing the same behavior. Now people are calling the community healthcare entrepreneurs to their homes and saying, take my BP, check my sugar, am I okay? So if you make it accessible and make it easy, it doesn't disrupt their day-to-day work, communities, once they understand the value of it, are willing to go for it. But I'll just ask a different question. I mean, while you're saying rural population, what about us? How many of the well-educated and easily access, those who have good access to preventive or diagnostic secondary screening, like you said, how many of them do that? My own family, I asked them, the women in my family, I had breast cancer a few years back, so I'm a big advocate of it. Go get your mammogram. No, what if they find out something? Yeah, I don't want to know. Okay, how foolish are you? But that is it's very difficult to tell people that go and get yourself checked because it's good, you'll catch something early and it's good for you. Most people are like ostriches. I don't want to know. Till I don't encounter something, why should I know? So it's a long, hard journey of transformation. Hopefully, as things go on, and you see much more of that. Access become better, it's cheaper for people, it's free for a lot of corporate employees. But still in corporate programs, you see how many people, 50%, 20%, 30% will take the free thing. But for senior levels, they'll say that unless you've completed this year, your promotion will be held up or some nonsense like that. Then they will go and get it done. But most people are starting to say that, yeah, it's important. But there is also, I think, a deep-rooted worry or mistrust that a lot of these so-called preventive checks are just money-making rackets. You're doing that so that you can find something, and so you can push someone into a secondary care or tertiary care to do some more checks which are very expensive. So there is the trust factor is also playing an important role here.
Thank you so much. So I want to stop here. You've been fantastic. I have not seen anyone go out. So I'm assuming there could be a lot of questions that I want to open it up to the audience.
So, if you don't mind, can I intervene for a few minutes?
Yeah.
So one is, this is relating to the points made here, right? So I made some notes. One is waste. I think if you have an electronic health record and if you can do it at a large scale, right? Compulsorily, everyone has an electronic health record. Otherwise, you can't access healthcare, right? Then you have artificial intelligence which can keep looking at your electronic health record and pick up waste, instances of waste. Because if it says that your treatment for a certain disease and you were given 16 medicines and you didn't require five of them, then you could easily have an engine that picks these things up and perhaps warns the doctor first and then later on intervenes more directly. I think electronic health records and artificial intelligence can do that. The focused factory, I think, we can't look at numbers at the individual level. The advantage of the focus factory is that you can aggregate data from 1,000 joint surgeries. So you have normative data on consumables consumption and consumption of time of the doctor, all those, and how many people have complications. You have normative data. Unless you have, you can't do it at St. John's alone. You might need to do it aggregated from 50 focus factories, which are all doing joint surgeries. There are 10,000 EHRs now available. You can analyze it and come up with some normative data, which at least allows you to pick up the outliers. You may still allow a lot of standard deviations as acceptable, but if there's an extreme outlier, you know that something is wrong is going on there, right? And then as far as who sees a family physician, I agree. I think the status, that's why I don't think we should call them family physicians. Please call them comprehensivists and tell them that the specialist reports to you. The specialist has to refer the patient back to you. The specialist has to get your permission to see the patient because the patient cannot see a specialist without going through a comprehensivist. And increase their salaries. Give them salaries in proportion to their skill sets. If a generalist, comprehensivist is seeing pediatrics, a lot of obgyn, preventive treatment, cardiology, nephrology, surely they deserve a better salary. So I think, I just thought I'll share that more for the benefit of the larger audience. But we'll now take questions. Yeah.
Yeah, sure. Yeah, hi, I'm Shanti Mathur. I run an e-commerce platform for medical equipment. I was really, there were a lot of interesting things that I heard from all of you. And I have a final question, but let me just to set the context. Like Meena ji said, and Dr. Arvind talked about in the last preventive health thing that there are a few patients who come and ask can you please check my how my status, and these are probably few people who are proactively managing their health, and they listen to the doctor and they do things. But I think vast majority of us want, but probably in the rural as well as urban setup, want quick fixes. Not even cure. I mean, they'll probably want to say, can you relieve my pain, and that kind of thing. But put in the context of the rising NCDs, non-communicable or lifestyle diseases countries facing today, one major aspect is managing the diet. I mean, as they say, it's what you eat. You are what you eat, right? And that is a significant portion of how you manage those diseases, right? Lifestyle diseases. So I was very interested in knowing what Dr. Kasturi talked about in the VCFS such whatever you said. You talked about the NGOs, you talked about the community health workers, and you also mentioned faith, So, but when it came to the Indian context, you did not elaborate on how faith can help with, better health in our in our country, right? And I feel that maybe managing the diet and lifestyle is something our religions or religious leaders can probably influence vast majority of our masses. And so I would be interested in knowing all of your thoughts as to how faith can, I know the efficiencies and the models and many other things that we have discussed in the book and today in the panel, but this is an aspect I would be interested in knowing your thoughts. Not a 100% solution, but I think there could be, and I don't see this happening at all. I don't think our religious leaders are talking anything about how to manage how to change the food habits or how to manage the health through that.
No, that's why I said in the UK you have the integrated care pathways, which formally include faith leaders. That has to happen.
Well, just to say one or two sentences. I work in a Catholic mission hospital. There's a lot of faith in the environment. And however, we do run a course for a Catholic priest group before they become priests on healthcare to enable them to do what you're saying, which is when a priest talks to people about the importance of including diet. I mean, not just diet, but the rest of the lifestyle, it does have a difference. But we haven't formally done that with other faith-based groups. But this is what we do, and to some extent, I think it does help.
I've heard all the ideas from the book and from all of you. The one thing that I'm missing is how to increase the number of doctors and nurses. And we've had sessions in the past here which have indicated that it's simply a matter of artificially that the number of seats are controlled, either by the government or by the medical council or whoever it is. Why not open up the number of medical colleges and seats both at bachelor's and master's level and increase the number of doctors available? I mean, A, you've shown statistics saying that you don't have enough. B, because of the shortage, people have to pay huge money just to get into college, and then they want to see how to get a return on that investment through various ways. So it would seem like one obvious requirement for this whole thing is to increase the number of medical seats and nursing colleges and so on and so forth.
I think that's absolutely correct, except that one then has to have a mechanism whereby these extra doctors are directed to the places that matter. Because otherwise, the more doctors you have, they'll all want to go into private healthcare. That's where they go. So there needs to be a mechanism, like there is, for example, in Thailand, where the Thai government makes sure that doctors go into primary healthcare. They have to sign a bond. So there needs to be some sort of check on that. Otherwise, you'll just have more and more doctors in private healthcare.
Yeah, well, from a medical college, I agree with what he says, which is we've got two problems. One, because of this massive denominator of 1,400 million people, any ratio in India is not up to benchmark because the denominator is simply too huge. So what about the doctors we are producing? It's more a distribution issue than a production issue at times, because all of them are here down 12th Main and 100 Feet Road. They're not where, like he said, where they are sort of quote unquote supposed to be. Now, our own students, we have in St. John's, we've got a system where a student signs an undertaking when he joins the medical college saying that he will spend 2 years of rural service when he finishes his MBBS degree. And many of them do it, no doubt. But the feedback of youngsters when you tell them that you've got this bond to sign, whether it's a government bond or a private medical colleges like ours, is what about the facilities there? We don't have, going forward to build a career in a rural area, I want a school, I want an infrastructure which allows me to build my family and my life there. And unless the government gives me that assurance, I'm not going there. I'm staying right here where I'm comfortable. So it's a sort of a little chicken-egg business in the sense that if that infrastructure, quote unquote, develops in the hinterland, you will have more people going there. And if more people go there, the distribution will change. And you can actually produce more graduates. There's another problem with producing more graduates, which is the quality of the graduates you produce. And that we are having a huge problem with. We have 600 and odd medical colleges in India. But the really good quality colleges that produce graduates who are of a reasonable quality, who've got competencies of the nature that their book suggests, which is a comprehensivist competency set, is really not that many. Not that many medical colleges produce that kind of a graduate. Because of the quality, the standards of medical education, unfortunately, are very diluted in many areas. So these are some of the things that probably are the other side to just increasing the number of medical colleges and producing more graduates. Distribution and quality. These are I'm just saying, two other issues that one needs to keep in mind.
Can I ask?
Can I say something?
Is it okay?
Yeah, so just want to add, in the book we have said more aims will just make us sicker. And just to paraphrase that, for doctors, I think as per WHO norms, if you include the Ayush doctors and all the other physicians, we actually have, as per the WHO norms, but there's a severe maldistribution. All of them are practicing in Indiranagar, right? They don't go to the villages. So, but the solution to this, that is not training more doctors, because more of them will then come to Indiranagar. And how do doctors maintain their income? They maintain their income by doing more and more when they have fewer and fewer people. If I'm seeing 10 patients, I'm going to charge each of them 1,000 or 5,000 rupees worth of treatment, whereas if I see 100 patients, I'm good at charging less, right? So actually producing more doctors, especially producing more super specialists, can accelerate the cost of care without improving quality. Because a lot of this excessive care actually diminishes quality, right? For example, they were talking about health checkup, right? We have what is called the master health checkup, which is one of the most useless inventions, but it serves the corporate hospitals very well because it acts as a sieve through which they can capture people with small abnormalities and one or two things for whom they can do more advanced investigations at higher cost. So I think increasing the supply of medical care is not the way to go unless you control the quality and the distribution of medical care. So I think that's the point they were also making. I just thought I'll add that because it's also discussed in our book. Questions? Yeah.
Is it okay if I ask? Oh, yeah. Hi, I'm Varsha Sridhar. I'm interested in occupational safety and health for workers. So as per the recent estimates, it's supposed to be 450, in the Indian labor force, 450 million people are expected to be migrant workers, of which 90% are informal migrant. So it's a huge population, and it's an itinerant population which is expected to increase with climate change, people having to undergo distress migrations. Given this kind of a huge numbers, how would the principles that you've spoken about having community health workers being trained, about the micro-entrepreneurship models that you've talked about, how would they work out in these populations?
I don't mind taking a shot at that.
Yeah, please go ahead.
Migrant health, the two things that we know are that India is the largest source of outbound migrants in the world. That's one. Secondly, it's got about the largest number of internal migrants, that means between states, in the world. So therefore, your point is very well taken. We have a huge number of people who move. We are a very mobile group. We keep moving from one place to another. But if the system, one of the things that they're talking about, the book talks about universal health coverage. Now, what is our existing system supposed to be doing? The existing healthcare system in our country, there is a healthcare system in our country, BTW, in the sense the government has got a fairly well written mechanism of delivering healthcare to its population in terms of, health sub-centers, now health and wellness centers, primary health center, community health center, taluk hospital, district hospital, state hospital. And this network is fairly well described. What each level is supposed to do is also very well documented. So the only way in which we can reach migrant workers is if that system works. If, for example, in an urban setting, which is where a lot of migrants come into, now even around Koramangala and Austin Town and those areas, there's a huge number of migrant workers. So if the urban health mechanism, which is supposed to be well documented, works, then you actually have got a point of care for everybody there. It's just that the whole thing doesn't work. I mean, as it is supposed to do. If there is a doctor there starting 8:30 in the morning, and a team, not just doctor. Doctor is only one piece of the puzzle. There is the community health, the urban healthcare workers, nurse at the urban health center. I mean, all this is there, then why will a migrant worker not access the system when he needs it? And drugs are available, chronic medicines are available for a month if necessary, all antihypertensives and, but it's not like that, and that's the reality. So, if that system is in place and delivers, comprehensive health care of the nature that the book talks about, I think even the migrant health worker will be covered, should be reached.
So just to add to that, if all of us had an electronic health record, we would have anywhere banking, anywhere health, right? It shouldn't matter whether your ICICI bank account is open in Hyderabad and you move to Bangalore. Same way, you have comprehensivist in Hyderabad and Bangalore will use the same EHR. So they have full record of what has been done for you since the time you were born on their EHR, right? So it should not matter whether you're a migrant worker or living in a place forever. So we had a few questions here. We have a question here, and then we have a couple of questions in the back there. I think we need to get a mic to them. Please.
Yeah, I have a question for the authors. You have mentioned as one of your principles that the government should be the driver and the orchestra leader to implement it and execute the mission possible.
Yeah.
My concern is that while the government is excellent at collecting taxes, and therefore they would be able to provide the finance and subsidy or incentive for people who can't afford good care by having lower cost of insurance, they are hardly the people who will take it forward. They are busy in elections all the time, and they really don't have the time for medical health care. It's well driven by the private sector. They're doing some excellent stuff. You can see from here as well that each one has got the right kind of creativity to really implement and do a great job. So government's role should be restricted in making sure that finances are provided, but the creativity.
I'll respond to that because this is an important point. When I say the government is the orchestrator, what does the conductor in an orchestra do? He tells the instrumentalist what notes they have to play, right? That can be the minimal role of the government. I'm not necessarily saying that is the only role of the government, but the government has to somebody has to set rules. Somebody has to say that if you want to go to a specialist, you must have first seen the comprehensivist. The guy who runs the hospital, if he's a private guy, he does not want you to go to your comprehensive. He wants you to come straight to the hospital. You cannot have the private sector controlling the organization of healthcare. They can deliver healthcare, but the government should put rules as to who can go to which hospital when. There should be standard, sensible rules. I'm not saying the government should become bureaucratic and do this nonsense, but I'm saying they're doing a very good job with UPI, and we have sent vehicles to Mars, and so the government is capable. And if you take the countries with the best healthcare in the world, they all have a universal health coverage run by their governments. There is no single example of a country which has universal health coverage run by the private sector. So it is just an oxymoron to say private sector and universal health coverage, especially in a country like ours where there is so much income inequality. right? So I don't think you can even say that and get away with it. You can say that the government can contract with private players, as I mentioned, but that has to be based on a lot of
competency
rules.
lies with the private sector. For
That's why
example, in Apollo Hospital, yeah, they may charge for profit, that is fine. But as long as they are also willing to spend some part of
Correct.
the profit
And the
which they
taxpayer,
make on
yeah,
the poor.
no, the taxpayer should use,
opposition.
we should use private players as contractors. I should tell Apollo Hospital, I'm going to send you 10,000 bypasses, this is what you're going to charge me, this is the outcome I expect, right? And we can get normative data on that. There is global data, there's also Indian data, normative data. So you should hold them responsible for clinical outcomes and costs. So I think we can do that. We are
Swami,
not saying purely government.
I want to add that I don't know how many of you saw the kind of collaboration that happened between government and private during COVID. So it is possible. There used to be one WhatsApp group in which I was also part of, where we had the biggest minds in private healthcare, the most senior officials from the government, all of them coming together to address the problem. And when they put their minds together, I think we did a fairly decent job in this country. Of course, one could argue that it could have been better or worse, but it is possible when government and private come together, you can actually get much more than the sum of the parts, provided there is, but the will has to be there to make it work. If that was a crisis, so everybody came together. In a non-crisis situation, what are the incentives for people to work together in a manner that is beneficial for both? I think if that can be sorted, then it is absolutely, you're absolutely right. Competence lies here. Quality control, SOPs, payer, those roles are what the government possibly needs to play to make it the best.
Hi, Meena. Meena, the question is for you, Meena.
Can you your name?
Am I audible, Karthik? My name is Karthik.
Okay.
Just with what she spoke a little while ago about the integration of the public and the private sector and the best of minds during the COVID times. Sorry, I don't mean in disrespect, but I failed to understand how and why was there an inefficiency and, about this whole COVID shield. It's supposed to be from one of the best medical device manufacturing companies, AstraZeneca. How do you see that as a failure? And apart from that, I have one more question to shoot. What are the corporate social responsibility initiatives that Portia Medical has undertaken to promote preventive healthcare and wellness programs, particularly among the vulnerable populations and rural illiterate masses? How open are you with CSR initiatives? As a follow-up question.
Yeah, the second part is a simpler one. Yes, we work especially with elder communities who are vulnerable, who live in locations which are far-flung or not being served. We work a lot with them on the preventive and curative aspects also. So that's Portia does that, and happy to continue to see what else we can do in that space. Now, when it comes to, I don't have all the answers of what else we could have done to make the vaccine delivery better. I'm not going to comment on the quality of vaccine, was it the right thing or not. But in my view, the size of the problem that we were faced with of delivering vaccines to the most far-flung locations, I think we did a phenomenally great job. No other country was able to do of that scale in the short time that we did. And I've been part of that group, and I'm very proud of what we did as India. Now, different matter, should we have taken Covishield? Should we have done something else? Was that the right thing? I can't comment on that because I'm not an expert on that part. But definitely the way we rolled out that program was exceptional.
So we have 5 more minutes, just 2 questions, please. And please ask the question directly so that we get as many questions in as possible, yeah.
Hi, I'm Dr. Protojit, and this forum I need to clarify, that's not a medical doctor. So I spend most of my time in the IT industry, and the hospital systems completely amaze me because what you're talking about, that left eye, this particularly to you, is that there always will be a specialist solving a problem. But there's a general person who manages it. So if I just flip over to the IT industry, an account has a problem. Now, let's say my IT system has a problem. It's either the web front end, it's a back end, or it's some intermediate layer which has a problem. So the problem is always going to be solved by a specialist. But we have something called a project manager. We have something called an account manager who manages it. I see it completely missing in the hospital where you don't have a patient manager or a patient case manager, which is similar to the book of this comprehensive role. So I think a big role is missing there, that every patient needs to have some kind of a person who kind of owns that patient in terms of, at least with respect to that hospital. So as far as I'm concerned, suppose I am that person, that whenever the person comes, I am the person he comes to. And I may have like 500, obviously there's a cost to keeping this overhead of the person liaisoning with the patient and taking care. But if you had that layer, then this problem would be avoided. And this person has to be a medical person also who understands the full longitudinal record, as you call it, and see what's been the pattern and what next treatment he needs to do. And it goes back to the point he was making as well, that he has to refer you to someone to really go. So the hospital said, look, hang on, you can't come to a super specialist at all. You need to go to your case manager, your patient manager, or your whatever you want to call it. So go to that case manager, he'll decide where you need to go. Because otherwise I'm lost and I'm going to a specialist, and the specialist can only do that. Like if I only got a hammer, I can only hit the nail, right? So if I am, it's no fault of the specialist. His domain is only related to that particular area. So suppose I'll give you an example also just to clarify. Like I had some issue that was actually requiring, I had a pain in my hand, and I went to a doctor who says, oh, this is a very common carpal tunnel syndrome problem, and I think it's pretty bad for you. He twisted my arms here and there. I won't mention which hospital. And said, straight away you need to go and get this treatment done. And by the way, it's a very simple procedure which they do it for the initial pain. So I was a little hesitant. That didn't look that painful and could be cured. So I went to a rheumatologist, and he had a completely different view. He said, okay, you're got this problem. This is a problem. Yes, what the surgeon told you is also valid, but first let's put you onto a little bit of a steroids and all the prednisolone and all that, and it could be better. I'm sorry. So, and then it completely changed, and with that treatment, I'm perfectly fine now. So I think I made the point that you need that.
Make it easy. I agree.
But how do you make it happen then? You are one of the...
It's not happening. That's what I'm trying to say. I agree that there should be a generalist, but there isn't one.
But you think it's required for
100%.
Hello, hi. I want to ask about the intersection of healthcare and mathematics and statistics and people from policy. So I want to ask whether in the book we have touched or covered this aspect, and what are the channels? Do we have channels where people from these seemingly polar opposite fields meet and?
No, that's not in the book.
Okay.
Can you get next person, please? Last question. Can you please
My
tell
name is Sujata.
Yeah.
So I've spent most of my adult life in the US working in healthcare, also implementing EMRs. I just want to sort of point out, I think India is amazing the way it has handled COVID, so kudos to the COVID team. The second thing is, I think I'm coming to India after a very long time, so I'm seeing things very differently, perhaps from what others may see. I think India offers choice, and yes, there are people who need health coverage who cannot afford it. Yes, but the thing that when you mentioned about universal health coverage, I want to say in the U.S., what U.S. does extremely well is emergency care. Everything else, we spend the highest amount of money and get the least amount of treatment in terms of GDP. So I'm a little wary about this universal, this person that you persona that you had mentioned about sort of gatekeeping the care, because I can see that becoming a cause for nepotism and preventing care, appropriate care, in a timely fashion. And I've seen that happen in the US time and time and time again. So that's one point. The second point, in the health system, there is the health system, there is the patient. The patient is a human being, okay? In the US, it has almost become so automated, and when you mentioned, they don't even touch the patient. The patient can go, and the physician is going clickety-clack, clickety-clack. Most of the care has been passed on to the nurse practitioner. The nurse practitioner does most of the work. the physician comes in, 5 minutes, and they bill. As far as the technology goes, in the United States, technology has always been driven by the insurance companies. Till Obamacare came along, nothing except the business processes and the medical equipment technology was developed. It took Obamacare to mandate EMR to call for, even then, it was only the mandate for hospitals and providers.
We have to start.
Yeah, sorry. But the point I was making was, I'm really concerned about that universal healthcare being the gatekeeper kind of, and it shouldn't become into a
you made a very
nepotism.
good point. I think the NHS has a gatekeeper mechanism, and there are other countries that have gatekeeper mechanism. Everything has positives and negatives, and I'm not saying that this has to be the way. This is one of the recommendations we have made, and we have to look at the balance of everything and decide what we want to do. But thank you very much, and before we end, we are going to have similar events in Delhi, Hyderabad, and Chennai. We have a website called missionpossible.in, if possible. Take a look at the site and interact with us there. And so thank you all for coming, and we are closed now. Thank you.